Amazing. I think we have Nancy here. Nancy, whenever you're ready, if you want to say a quick, short hi, and I will just start the meeting.
Okay. Well, thank you. What a privilege. This is my passion, um, and I'm grateful for the years I've had and watched things evolve in terms of MS treatments, and movement towards ending MS. So thank you for asking me to join you today.
Thank you, Nancy. If everyone agree, we will start. Moment. One moment. Okay. Hello, everybody. Welcome to our second Northern Speaker Series webinars organized by the UMSSC team. Thank you for joining us today. My name is Bruce Danesh, and I'm an ambassador with the MS Society of Canada. I'm also the founder and president of UMBC MS Student Support Club, and we are a student lead, not-for-profit organization at the University of Northern British Columbia that follows the mission of the MS Society of Canada, which is to connect and empower the MS community to create positive change. It's my pleasure to be moderating this webinar today with Marcia Spanier, the Coordinator of Community Services of MS Society of Canada. Marcia will be available via chat if you have any technical problems or questions regarding the presentation. A few housekeeping notes before we start. Please make sure that both your microphone and video are muted, just for the better quality experience. Please note that this webinar is being recorded and can be viewed subsequently. The names of all participants will remain confidential, and no personal information will appear in the recordings. The recording will be uploading on our YouTube page by Tuesday next week, and Marcia will email the link to you as soon as it's ready. We will have designated time at the end for your questions, so I do encourage you to write your questions down and ask them at the Q&A time. Meanwhile, you can type any questions you might have into the Zoom meeting chat box, which you can open using the icon at the bottom of your screen. We will either read your questions out loud or call you by name and unmute your line. For today's webinar, we are very fortunate to have Nancy Bogle. Nancy is a registered nurse with more than 20 years of experience supporting persons who live with multiple sclerosis, their caregivers, and families. Nancy began her degree in nursing at the College of New Caledonia and graduated from a Bachelor's of Nursing program at UBC after completing her bachelor's at Acadia University in Wolfville, Nova Scotia. Aside from a short stint exploring community health and pediatric neurology work, most of her career was focused on multiple sclerosis. Nancy first came to the UBC MS Clinic in 1995 and was involved in the initiation of the Special Therapies program for the first approved disease-modifying therapies for MS. In late 1996, Nancy moved to the area of MS research at the UBC Clinic. Although she left UBC in 2018 to pursue graduate studies, she currently works in a private neurology clinic with an MS specialist. Nancy is a published author, experienced presenter, and considers the ability to work with persons and their families with MS a great privilege. Before I turn the microphone to Nancy, we have another special guest, Darlene McIntosh, who is a Claytonay elder, and she will give all of us a traditional welcome and open this webinar with a special prayer.
Howdy. Well, it's my honor and pleasure to be able to give a prayer and a traditional welcome to Claytonay's territory. And welcome, Nancy. I am a cultural advisor also with the College of New Caledonia, so it's my pleasure to be here. I'm a really good friend of Brianna Robinson, and so we together will create a sacred space for us to do our work in today. So the first thing I want you to do is to close your eyes, and then I want you to take a nice deep breath throughout your whole body. Nice deep breath throughout your whole body. You're doing a cleansing breath, letting go of everything that does not align with the best that you can be. Just let it go for now. Don't put your energy into that or energy into tomorrow. You want to bring all your energy into today, into this very moment. as we open up to listen to what Nancy has to say. Breath is very important, connects us to ourselves. It reminds us how important breath is. The day you were born, you took your first breath, and you never stopped breathing for 70 or 80 years. And how wonderful is that? So we take the next deep breath into our feet. We feel our feet sink into the deep, rich soul of Mother Earth. And there she grounds us into today, into this very moment. You can smell the richness of her soul, can feel it between our toes. And as we settle in, we're probably all sitting in a chair. Feel your body sink into the chair, letting it support you to what will be taking place for this next 3/4 of an hour or so. So we ask Creator and the Grandfathers to come be with us today. Thank you for the new beginnings of understanding as we gather, moving forward to a brighter future, acknowledging the ongoing battle with multiple sclerosis. Thank you for reawakening the trust that we have within ourselves, promoting awareness and supporting each other in finding a cure for MS. Thank you for helping us to see the beauty of our gifts as we live each day, finding innocence within our beings, seeing ourselves in our own true worth. We are not here for our own person, but those who we support and nurture, helping all to find their way as we are guided by Spirit to be here. Spirit is always with us. We pause, looking inward, helping us to see who we are, illuminating that which we haven't seen as yet. We come together here in the North. What is the Northern energy? It is about knowledge and wisdom. We take this home with us to share, creating healthy, strong communities as Creator guides us. The ancestors give us the energy to continue, and the grandfathers and grandmothers are always here, ready to be of service. Mother Earth, you're always with us, providing, nurturing, and loving us. We take a moment and send you energy that will help nurture and heal you. We walk on Mother Earth, leaving no footprints. Creator, you who gave us life, who have taught us to give and receive in balance, be with us always as we journey the good red road back to you. We, the Clayton Tenay Nation, have been on our traditional lands over 9,000 years as supported by lithic evidence. The changes have taken place over thousands of years supports the enduring strength, courage, and fortitude of our peoples. Our governance through the Batlas brought balance and harmony with our brothers and sisters of other First Nation people. Clayton Tenay's clans are Frog, Luciliu, Grouse, Utsut, Beaver, Sa, and Bear Sus. Through this system, we know who our family connections are. Through our oral history, the use of legends told of our travels, our hunting and fishing territories, our trading practices with all peoples. May remember and hold steadfast in what Creator's blessed us with, and that is our traditional territories. Our ancestors have always welcomed people to our territories. On behalf of Clayton Tenay's elders, our youth, community members, and chief and council, it is absolutely our honor to welcome each and every one of you to our traditional territories. All my relations must see. Thank you.
Wow, it was amazing. Thank you so much, Darlene, for your special welcome. Now we'll hand the microphone to Nancy Bogle with her presentation, Looking Back, Looking Forward, the Changing Landscape of Patient Care for Persons Living with Multiple Sclerosis. To you, Nancy.
You're on mute, Nancy.
There. Can you hear me now? Okay, my apologies. I'm a tried and true Luddite. Thank you, Darlene, for the welcoming and opening prayer. Thank you, Bruce. Thank you, everyone, for the opportunity to speak about something that is my passion and has been pretty much my life's work. Okay. Rihanna gave me a tall order, and I was trying to figure out how do I speak about everything, because the beautiful thing about MS now is there's an absolute overabundance of information. And how can I put this in to a talk, and a succinct kind of talk? I thought a lot about where we're at right now and with COVID, and how exhausting it is, how difficult for people. And I don't know about everyone else, but I spend a disproportionate amount of time on Zoom looking at slides. And so I decided that I would set my slides aside. You can have my slides if you think you'd like them, but I would just talk to you as a person who's worked in MS about my experience, about what knowledge I've hopefully acquired over the years. So bear with me if I don't have any fancy slides behind me. I can assure you I have them prepared if you'd like them at another point. I'm supposed to say a little bit about me. And so if you bear with me, I'll give you a bit of context. I'm from Nova Scotia. And the North. I am very fortunate to have those two places to call home. My family come from Nova Scotia, a rural area, and my father at 14, which is hard to believe, lied about his age and went to Korea. He came back from Korea, got a veterans grant, and that was the only way he was able to go to university. He went to Acadia University, then went to Dalhousie and graduated with a law degree. And then came out west because the Maritimes is famous for having its best leave and go elsewhere. He went looking for opportunity, and he found tremendous opportunity in the north, in Prince George. He arrived in the late 60s, early 70s, and that was a time when big corporations were kind of coming in and looking at small, hardworking loggers and sawmill operators. And my father worked with those people closely to make sure that they had a fair sale when they sold their sawmills and their logging rights. I like to think that was his humble maritime roots. He related to those hardworking people, and they in turn related to him. Prince George was very, very good to my father, and the people continue to be amazing to us in terms of their honesty, their sense of community, the embedded culture, the resilience, and the genuine nature of the people. After high school, I left Prince George. I went back to the Maritimes to pursue a degree in English literature, which is quite far removed from nursing, actually. And I got restless, and I decided I needed to know what I was going to be at the tender age of 19. I had to, cement my next 50 years. Some of you might know this show, many of you won't, which will date me. I made a decision to go into nursing based on watching a program called St. Elsewhere, which was about a hospital in Boston. I liked the dialogue, so that was my decision. And that's why I started out in a nursing program. I wouldn't suggest to people that you necessarily make your decisions about your life's work based on a TV show. It could go sideways. For me, it didn't. I came back out west and I went to CNC. I found myself in an incredible program, a very supportive environment. I got to do practicums in Prince Rupert. I spent time in Quesnel. I spent time in Vanderhoof. It was an excellent program. I did decide to leave and go to Vancouver for a while. I was actually en route back to the Maritimes. I wanted to go do outpost work in Labrador. So I was going to go do my rural nursing program. I ended up staying in Vancouver, however, and after working a bit in cardiology and respirology, pediatric neurology, I fell into MS by chance, and I've never looked back. It is my love. In 1995, I was asked to head what was called special therapies clinics. I had very little, real positive knowledge around what MS was. I just thought it was a chronic neurological condition. When I actually joined the MS clinic, it had been running probably for about 15 years. I'll just give you a bit about the origin of MS clinics in general. In the mid-70s, people realized that MS required an integrated care approach. And so the decision was made to try to develop these specialized clinics, not just in Canada, in North America and in Europe as well. So the first one in Canada actually was in London, Ontario, and it was headed by, some of you may recognize the name, a brilliant neurologist and a wonderful gentleman. His name was Dr. Don Patey. And Don Patey came from the US and went to London, Ontario, and started the first MS clinic in London, Ontario. Stayed there for a few years, and then he was convinced to come out to Vancouver. And in the early 80s, the MS clinic at UBC opened its doors with Don Patey at the head. In addition to having the concept of an integrated and comprehensive kind of care for MS patients, Don Patey was revolutionary and a pioneer in MRI. And he recognized that by consolidating care and getting MS patients together, we could start to do studies. And then we could start to see whether or not some of the treatments would work or not for patients. But in order to try it, you have to have people together. So he started the MS clinic at UBC, the MRI program at UBC, and the clinical trial program at UBC. The thing that happened with MRI, which the first one was about 1981, when we actually visualized on MRI that we could look into the brain and see that MS activity was going on, was pivotal. It really was the turning point for treatment and research in MS. By looking into the brain, we could look early once we tried someone on a medication as to whether or not the medication was making a difference. And otherwise, we were relying just on people's physical examination and findings that could be inconsistent. So the MRI, the window into the brain, turned MS on its head. What we now have is MS care, in addition to the research part, being a standard, the clinical care, and these clinics all over the country are now a standard of care for MS patients. We expect patients to have access to comprehensive and integrated expert care. Out of the idea of having these clinics, these freestanding comprehensive integrated MS clinics, became the realization that while they were comprehensive and integrated, they were generally, for the most part, in large urban centers. And what does that mean for most people? It means they're having to travel, or there's an imbalance or an inequity in care. So in the 80s, late 80s, the concept of regionalized care, and I'll speak more to BC because this is where I've done my work, the concept of regionalized care really started to evolve, and there was an interest. And at UBC, what ended up happening was the Prince George Clinic was developed. The Prince George Clinic is associated with the UBC Clinic, but it is now a freestanding clinic, and they have a full-time nurse, an occupational therapist, a part-time social worker, and I believe a part-time physiotherapist. Specialists still come from Vancouver to provide that expert consultation, but they are freestanding clinics, and that's huge. In addition, there's a clinic in Burnaby that services the Fraser Valley. There's a satellite clinic in Kelowna, and clinics will continue to evolve. But we need to do more. There are still pockets in this province that don't receive expert care. Expert care means that your underlying condition, MS in this case, is being treated with optimal therapies, recent research, and it puts things in remission so you go on with your life. The other thing I think about expert care is there's validation, and people need that. You're validated for your options, and you're validated for simply for your underlying condition. I would like to see us travel to outpost and rural areas. I think there's an important need for us, as do some of my colleagues, to be on nations to provide care. I have a patient who calls me from a remote nation in northern BC. He makes my day. He calls me periodically and he'll ask about an appointment, where the appointment is, what time it is. It's in some ways you could say it's not really my job. He could call the secretary, but he always calls me because he knows me. And I'm able to tell him when the appointment is, where he should go. And he's had a rough go and he's now stable. And I'm happy to do those what are small things really for him. He's trying to navigate a foreign labyrinth. And I'd like to think that I'm able just to give him a hand along the way. I really love trying to help him. He makes my day. And one of the reasons he makes my day is every day when he calls me and asks me for something, after I've addressed his question, he simply hangs up. He never says goodbye, he's just gone. But he's an example of our need to go out to outlying areas and provide one-to-one support. COVID, as I alluded to earlier, is exhausting, no doubt. Hopefully by the end of the year, we'll start to see some lightening. There has been some silver lining, however, in terms of care and in terms of MS. And how this will translate, we're not quite sure, but certainly healthcare will not go back to its former mode of delivery. The government is showing signs of a commitment to telehealth. And what will happen with that is it will be able to evolve and expand the care for MS. So we'll be able to fan out more services to remote areas, utilizing whatever form committees come up with telehealth. That won't replace seeing your neurologist person to person, but it means in between in-person visits, we should be able to provide expert care by a remote system, and it will be visual. So I think that's a very encouraging thing to see. If we go back a bit in terms of to the first treatments with MS, where I first went, which was the special therapies group at UBC, I started in 1995, and in 1993, the first treatments were approved for multiple sclerosis, relapsing remitting multiple sclerosis. They were injectable agents, and they were given either daily or once a week or every other day. People were so excited. We were so excited because it actually impacted the disease itself. People had about 33% fewer relapses and about 33% fewer lesions on MRI. We were so excited because it was the first time ever we were able to impact on the disease itself and not just treat the symptoms. So that's where I came in, and we started to get people on those therapies. What we did do at that time is philosophically, we probably put people on these therapies who had more established or slightly more advanced MS. And part of that was just because the treatments were new to us and we were unsure. Prior to any therapies really emerging for MS, care was supportive. We reassured people, we talked to people, we treated symptoms, we watched disease evolve and progress. And so that wait and see philosophy took years to really change, where we recognized maybe we should be treating early. As time went on, there was a bit of a lull, and then suddenly we started seeing more treatments come out. And in 2010, we actually saw the first oral medication approved for MS. And this was pivotal because the thing about the early medications is that they were injectables. And in retrospect, a few years after we had people on these treatments, we started to see that no one really wants to give themselves necessarily a needle all the time. For some people, the other thing that can happen is they would have intractable side effects that were really hard to control. And it was almost like flu-like symptoms. So people kind of had the hangover without the party. Long term, that's a quality of life issue. To stay on a medication that may be modestly impacting your MS, but makes you feel awful, it's a tough thing to do. So the emergence of newer medications, such as the orals that were well tolerated and easier to take, was another pivotal moment for MS. And that has continued. Once the floodgates opened, there was huge momentum and sudden worldwide interest into MS and treating MS and finding research. After the orals came out, then we started to see things like infusion medications, where people can go to a center and have an infusion, and then they don't come back for several weeks. In 2017, we saw the approval of a monoclonal antibody that actually treats relapsing MS as well as early and active PPMS. And this was pivotal because this was the first time we had a treatment that would actually act on progressive MS. 2019, we've had siponimide come out, and we're actually using that to treat clinically isolated syndrome. So that's before you even have a diagnosis of MS. So we're trying to prevent the conversion to formal MS. We're also using that with active progressive MS, secondary progressive MS. Trials continue. And if you're looking for trials, I won't speak to that now because I've been away. I don't have my finger on the pulse the same way I used to. So interest in trials is best looked for sourcing information. I would look at the MS Society. It's always a great, well-vetted reference. You can also go to clinicaltrials.gov.ca, and that tells you what's up and coming. Another thing I should probably mention is just the whole idea of stem cell transplant, or HSCT is what we typically call it, and that is also showing lots of promise in very active and aggressive MS. The Progressive MS Alliance is an organization that originated in Europe, and this group has tremendous momentum. They continue to lobby, push, pressure, and support for research and treatments into progressive MS. There's really no end to how much time and commitment they have put into an effort to try to address the progressive aspect of the disease. Other areas of MS research that are evolving include genetics. We now know that there are genes associated with MS. We know that there are susceptible factors. We've come to realize that exercise itself actually helps tamp down your autoimmune or inflammatory response. I'm always humbled by this because I recollect when I first started in MS, we would tell people, and that was just changing as I started, that you shouldn't be active. Being active made you more symptomatic, so it was better to rest. Inevitably, what would happen is the issue with that is twofold. And one is that by being inactive, people get more deconditioned. And then we now recognize that it was actually probably making their MS worse. And I guess thirdly, it's the quality of life. People need to have purpose. Now we know we can tell people exercise. It makes us all feel better. It's a protective factor for multiple conditions, and it's also protective for your MS. And there's nothing like people being able to impact their own condition in addition to, say, taking a treatment. What else are we doing nowadays? We are looking at the gut biome. We're looking to see how does it impact MS. There's a lot of research into that area. We are now looking at trying to fast track and diagnose MS as early as we possibly can, where there's any kind of minimal permanent damage or activity. And we found ways to use different techniques on MRI to diagnose. We've come back to using spinal tap sometimes because it can help firm up a diagnosis, and also ensuring that the diagnosis is accurate, that someone does have MS. MS still is a diagnosis of exclusion, and by that I mean that we rule out other conditions before we actually come to MS. We've learned to treat the whole person. I think that's one of the most important things I think about if I look back on my experience in the MS field. We used to just treat neurologically, and we used to treat what was on MRI. Now we really treat the whole person. And by saying that, we look at involving exercise, involving diet. We know things like smoking actually can accelerate MS worsening, so we try to support people around not smoking. We also encourage people to maintain a healthy weight if possible. And we also look at, the term is comorbidity. It means other health conditions along with MS. For example, diabetes or hypertension, high blood pressure. We want to control those things. All of those things, when well controlled, help keep your MS in a more remitted state or in remission. The other thing we try to look at now is personalizing MS medicine, trying to see if we can stratify or determine where a patient may go in terms of their MS. There's some early evidence now and some key features where we can sort of determine whether or not someone's going to have a really active case of MS or if it looks like it may be a little more stable. There was a term about 20 years ago, still bantied about even 10 years ago, and the term was benign MS. So benign meaning you have MS, but it's not really active. That simply is very rare, if at all existent. What we would say now is that you can only say a person has benign MS in retrospect, which means that you would be looking at someone 20 years down the road and then finding out that they had very inactive MS. But we really don't want to leave someone waiting for 20 years and watch them accumulate potential disability. So we've kind of taken that phrase out of our lexicon. The thing we do now is we treat. If I talked a little bit about clinical trials and what has happened as clinical trials have evolved, what I would say is that the early clinical trials represented the notions and the theories we had about MS at the time. So the early clinical trials, basically patients who went into those trials had more active and probably slightly more advanced MS. And that's because in a trial, there's always somewhat of a risk. So we were trying to treat people who were active to see if we could slow things down. What's changed now is we recognize we don't want to take that wait and see philosophy, which is very similar to the concept of benign MS. We don't want to wait and see how people do. We want to treat early. So when we diagnose accurately and early, then we do treatment as prevention. The other thing that we do too is that when we look at clinical trials, we're also looking at things like how do these medications work, not just in terms of their efficacy or how they affect MS. What are things that we see in terms of, for example, biological markers? Why do some people respond? You have two people with very similar MS. Why is it that one person responds to a treatment and another person doesn't? So they're starting to analyze samples to determine if we can early on look at biomarkers to see what medication would fit best for the patient. Each year, the Canadian MS Working Group, which is a group of neurologists, and they're all specialized in MS. They're actually called MSologists. They sit down at a table. Normally they would do it in person. This year they had to do it virtually. And they come up with recommendations because to some extent, as things evolve, we still have regional variations in how people interpret things and how they treat. So the Canadian MS Working Group wants to work together so that we have a very consolidated and consistent approach to treatment. What came away from their recent meeting in 2020 is we use the Mcdonald Criteria, which is criteria by a neurologist that came out in the early 2000s and has continued to be updated. They use these criteria as a way to diagnose MS because it ensures early diagnosis and accuracy of diagnosis. And then the next step they look at, and these are their recommendations, is we get an early and an accurate diagnosis and we do early treatment. We start treatment as early as possible. And why? Because as the MRI advent showed us in the early 80s, even when people feel well and they're asymptomatic, when we look in the brain and on the spinal cord of people who are not on a disease-modifying therapy, MS is simmering even when we can't see it. The goal is minimal disease activity over time. And I've said this to myself over and over because to me, this is a sign of hope and just how much progress we've made. Minimal disease activity. That's an incredible thing. We're saying that we have the ability to act and treat and impact the underlying neuroinflammation that goes on with our current treatments. The other thing we look at is we want people to be treated when they're younger because we do know that they respond better. In addition to early intervention and early treatment, we look at what can you do and how am I evaluated in terms of if my therapy is working or not. And one of the ways in which we do that, or the ways we do that, they're threefold. One is the neuro exam. So you see your neurologist periodically. They'll look at your previous neuro exam, they'll do a current one, and they see how you're feeling. How do you look on neuro exam? Are you stable? Are there changes? We also count relapses, and that's where patients come in. You record how you feel. Let us know how many you've had, or if you've had any. And then thirdly is MRI. Equally as important is MRI, looking into that brain and that spinal cord, getting the closest look possible into the window of the brain and the spinal cord to see that the medication you're on is working for you and that things are quiet. And that is our expectation. How we do that is, what do we do if there's changes? So the recommendations will say that if you have a significant change on MRI, I'm going to keep that as a general comment, we may consider changing a disease-modifying therapy. If you've had an active relapse, we may consider changing disease-modifying therapy. And our MS care is so sophisticated now that we can use other modalities to test. So things like, in addition to the neuro exam and MRI, we do SDMI, which is our single-digit modality testing. So it's a testing for cognition. It helps us understand if you have complaints around memory or thinking. And the 25-foot walk, which gives us a real idea of people's endurance and balance as well. So there's lots of ways to assess people collectively and see how they're doing. Many people with MS will find they may change their disease-modifying therapy during their lifetime. And that's not a bad thing. It's something for people to try to get their heads around if they've been on a therapy and then they need to change. I would say what the great thing about it is that we have those options. Sometimes we use the term escalation, and sometimes people may require a slightly stronger medication to put their MS in remission and to achieve stability. What I like there is that we have this goal, and it's a reasonable goal, that we can achieve stability. It may take us a couple of medications, but we're able to generally do it. The other thing that comes into play, in addition to having the medication, is looking at our patients and our patients' role as making sure they have appointments, making sure they're set up with a specialist, that they have access to their nurse, and that we do things like health counseling around diet, helping with exercise programs, taking vitamin D. All of those things help, and monitoring for and treating for comorbidity. That is as important as your DMT and will help keep things in remission. One of the beautiful things about as people get older is that MS tends to quiet down. So late 50s, we are now seeing people who were on the early therapies, we're actually weaning them off. And their MS is staying stable because by nature, biologically, our immune systems do tamp down as we age. So at some point, people will be looking at stopping therapies or reducing the frequency of therapies and still maintaining that stability. I think what's so important to consider is, as things evolve and as we have treatments, that when you choose a treatment, you choose it early in conjunction with your neurologist and your nurse, but we also recognize it's a shared decision-making process. There's so much information on the internet, and there's lots of anecdotal experience, but MS affects everyone uniquely and differently. And we also have to factor in what people will be compliant with, what they feel they're comfortable taking with, and where's your risk level as well. Some people would prefer something milder and watching carefully and seeing how they do, as opposed to taking a more aggressive approach. The goal now is that we can treat MS in people so that you go on with your lives. And my experience in my practice has been watching people have MS initially at the forefront, and then over time working through that process and then going on with their lives, finishing university, getting jobs, maybe getting married, having babies, those sorts of things, having grandchildren and enjoying them. Periodically, MS may reappear and you may revisit the diagnosis, but you work with your team to put it back in place again so that it's not always at the forefront of your mind. When we're looking at movement forward, where is research going? The incredible thing is that 25 years ago, there was a paucity of interest in studies in MS, and now there's anything but. Everywhere you turn, there's interest, there are side studies, there are people who want to know more, and there are treatments and research studies that are interested in trying to eradicate the disease. We continue to look at the gut biome. Regeneration always continues to be something that's explored, as well as looking at neuroprotective ways to prevent the nervous system from damage. And again, we continue to lobby and push to see how do we treat progressive MS. In some ways, where we're treating MS very early as prevention, we may help make that category of secondary progressive MS very small, maybe obsolete, if we continue to do the things we're doing with early remitting. No longer do we just take that reassurance approach or let's just wait and see. Treatment is of the essence and is important. I'll close with, why do I like this field? And I would say it's the ongoing relationship with patients. I often get to see people when they're in the provisional stage of diagnosis, then to diagnosis, then to maybe treatment options or supportive options, and out through the other end of that tunnel. And I'm privileged and amazed at the resilience of the human spirit and the gratitude and grace with which people navigate MS. Thank you.
So Nancy, there was one question. If you could expand a little bit more about active secondary progressive MS.
Okay. Well, that's an easy one. I was worried. I was like, somebody's going to ask me something about the COVID vaccine. So when we talk about active secondary progressive, so secondary progressive generally means that you've had relapsing remitting MS, and you now are having discrete changes that aren't real relapses, and people tend to accumulate disability. Active would mean a couple of things, and a neurologist would have to determine this. One would be looking at MRI, brain or spinal cord, and seeing if there's new lesions. So if we saw a new lesion and an active lesion, then we would say there's still some inflammation going on there, even though the patient may have had some time without any kind of real relapses, more or less just some discrete progression. Or it can also be that someone's had been very, very stable for a long time with some subtle increases in disability, but suddenly they have a very clear-cut relapse. Relapses are generally defined as reappearance of old MS symptoms or new MS symptoms in the absence of concurrent illness or fever or infection or fatigue that last for at least 24 hours. So those are the things you'd be looking at.
Any other questions for Nancy? It's a quiet group today.
That's a good thing or a bad thing?
It depends on your perspective, I think.
Oh, thanks.
Comment from Krista was a great presentation. I had aggravations of my symptoms after sleeping. Any comment on that, Nancy?
Aggravation of my symptoms. That's a very general.
From Isabel.
Yeah, that's quite general. Need to know how long they lasted.
Isabel, you're welcome to unmute and ask your question if you want and interact.
Yes, okay. Can you hear me?
Yep.
Okay. Yeah, my symptoms get aggravated after each night of sleep or after a nap.
What, do you mind me asking what kind of symptoms?
Numbness in my right hand up to my elbow, and I'm losing more and more my balance, and I also have numbness in my both legs, and I'm limping.
And they're worse after sleeping?
Yes, yeah. Either after a night of sleep or just after a 20 minutes nap. So I told that to my neurologist, and she said, I've never heard that before.
Yeah, because typically when people rest, it does improve symptoms because you're giving your nervous system time to regenerate, right?
And for me, it's the opposite.
It's the opposite. Yeah. It's hard. So I think you're at our clinic in North Vancouver. So if you'd like to call me on Tuesday of next week, then I could speak to you when I can see your charge, if that's okay. And we could review.
Okay.
Okay.
Thank you very much, Nancy.
You're very welcome. Yeah.
A few more comments of the presentation was great. Thank you so much for your time and passion.
Aw.
Any other questions anybody wants to share? Feel free to unmute and go ahead and ask. Love the format of not using slides. Very good content from Joanne.
I have a question for Nancy. It's Isabel again. So Nancy, are you at the MS office in North Vancouver?
I am. I'm there twice a week. Yes, with your neurologist. I recognized your name.
Oh, okay. So
Yeah.
are you a neurologist? Are you a chronic disease nurse?
I'm a nurse, and I'm very, very slowly picking away at my master's. My goal would have to do NP work in MS, but it's very slow.
MP, and what is
Nurse
MP?
practitioner.
Oh, right. Okay.
But yes, I'm there at the clinic where I'm at your clinic, Tuesdays and Wednesdays.
All right. Thank you very much.
Thank you. Yeah. Now I put a face to your name.
It's Sherry in Fort St. John. Thank you for the presentation. I just have a question. It's kind of more of a general question. As you probably know, Prince George's MS clinic has closed essentially to, I guess our MS office is closed. The clinic is still open.
Right.
Our struggle in the north is reaching the MS nurse and connecting with our local group up here. Do you have any recommendations? We all have a neurologist. Everybody's busy and understandably so. Any recommendations of how we can connect, since the MS clinic is struggling maybe to return phone calls and have a connection with us, especially being so rural? You know, I'm 5 hours away.
Yes.
I think about people that are 10 hours away north of me. Any recommendations on that with the MS clinics or connecting with our neurologists?
I think I think you've raised a really important point. I would say that probably, and please correct, you live in the north, so if I'm off base, please tell me. But my thoughts are that it's always been a struggle to some extent for people that are in farther away from clinics, but it's really magnified by COVID. Would that be fair to say? That you're just that?
Yeah, I would say that's fair to say. You know, I've only really been attached to the clinic for and really connected for the last 7 years. So I can't say past, like prior to that, but I know even trying to connect prior to COVID, I struggled. So, and I really have concerns with the people that have connectivity issues
Yes.
or, you know, just technologically challenged.
Yes.
So, and then, you know, I've had people reach out to me, you know, I've tried to reach the clinic and myself, taken 2 weeks to get a phone call back. And I know this isn't, we're not here to complain about all of that, but it's just a struggle. And how do we as North rural, what do we do? Who do we contact?
Yeah, no, it's a very good question. Sorry, and do you think it's worse now because of COVID? Is it your sense that it's worse?
It's hard to say. For me personally, I think it's pretty much been the same.
It's been pretty consistent.
The one struggle over COVID, obviously, is our neurologist hasn't come up.
Yes.
Puts on a clinic, and she hasn't been here in now going on a year and a half, almost 2 years.
And I can tell you that from the neurologist's perspective, it's very distressing. And, you know, many of us feel like it goes even outside of MS where people are concerned. The medical community is quite concerned about, in general, trying to do everything remotely, that we do need to see people. And what are we going to do about that? In the interim, there's a couple of things like I'm thinking is, well, there's, okay, the bright light would be, I really do think, and we're hearing this from the government, because now people have had a taste of telehealth, and so there's no going back. There will be that the technology will be utilized. I don't know how it's going to evolve or how it will roll out, but that will increase access for sure, so that you'll have you know, seeing people in person, but you will also have that interface that isn't just a phone. What for now, how do you reach your clinic? Do you call or can you email, or do you have any visual mechanisms?
Currently, phoning and email is what, like, I personally do, and I believe that's what most of the people our neurologist has set up appointments with video chat in the past, but again, it's few and far between, obviously, and but yeah, calling and emailing multiple times. So that's the struggle, and I know they're overworked and they're busy, and I get that. So where we want help is, who do we contact in a more timely manner? Because when we talk to a GP, for instance, you know, they can only do so much. And I'll give a personal experience, is that I had a relapse and I couldn't get a hold of the clinic and for almost 2 weeks, and knew I should have had probably about steroids, and eventually it all went away, because I'm not just going to be like, I'm just marching it up to the hospital to say, hey, let me come in. So my doctor has now said, here's a letter, take it in immediately, so you don't have, you know, this lag time, and you can get it dealt with immediately if you're feeling these symptoms or this comes back or whatever, which is great, but also shouldn't be up to her to do that. So if I'm feeling this way and I'm involved with the society on a regular basis, I can't imagine what people that aren't, how they feel. So who do we call to get medical help, I guess, in a sense, and correct medical help too. It's one thing to just talk to our GP, but you know, we want to talk to the nurses, or we want them to just email us back and say, hey, I don't know, I'm looking into this, or just some form of communication, not just flatline nothing.
Yeah, no, you raise a very good point, because you're right. Your family doctor it's wonderful that your family doctor is able to facilitate and provide you with, you know, treatment, supportive treatment if needed, but it doesn't replace the fact that should you be using steroids that often, what's really the underlying cause, how many relapses are you having, are you on the right therapy, that sort of thing. And have you been able to express to the clinic that you're not able to get through to them in a timely manner?
Yes.
Okay.
Yeah.
Okay.
And multiple people from my community have too. So it's a struggle that many are seeing, that I'm aware of, and I'm sure other people have this same issue too. You know, and I honestly, and I just want to say, I wish all neurologists had the passion that you have and calming bedside manner per se that you have, because I think that's a struggle too. But
I want to think about what you had to say, because it feels like you were left out there and you have a good point, and what do we do about that? And if it's okay, I'm going to take it back to our neurologist and discuss it with her, just about, because I think you're speaking to something that we sense is going on, and how do we mitigate it? And you're very fair, because you're saying is, given COVID, it's difficult. Things are working on a skeletal staff. What work volume like? But you know, these are specialized clinics, and how can we best support people in a timely manner? Because you're right, it's part of healthcare.
Yeah, and I mean, it's great that we have these virtual opportunities. We have Babylon Health, or we have, you know, these options to talk to somebody. But again, we need the specialized help.
Yes, you do.
And getting it in a timely manner is very important. And
it is.
And I know there's other people in the community here that have struggled, and it's detrimental that they get the help and they don't know who to talk to. They don't know where to go. So here I am asking for them and for myself, because it is a struggle. So
yeah, no, you're an ambassador around it. And I do see that I think that we will see some evolution, and there will be definitely more accessible things. But in the interim, what do we do? So could you leave that with me and let me think about it, and I'll discuss it with the neurologist. I don't know how I can best communicate back to you. I guess we'll do it through the society, and I'll figure out that piece. But I just want to sit on it, and I'd like to give some feedback to our specialists down here, how they think we might be able to mitigate it. Yeah.
I appreciate that, and I can pass along my email or whatever phone number.
Okay.
Absolutely. Yep.
Maybe through the moderator, and then we'll go from there.
Yeah, Nancy, if you ever wanted to, come up with another presentation, we can definitely schedule something else, and I can invite, especially the BC people, because that's more what you're talking towards. But we can definitely set something else up for a BC centered kind of approach for sure.
Yeah, and like I said, I know it's worse through COVID, but it has happened in the past and prior to COVID. So it's just an ongoing, and now it's snowballing, and now it's 10
and
times.
that's fair. So it's a pre-existing issue that's been magnified by COVID. What do we do about it? Yeah, and that's
and it's certainly not just a BC issue. Like Alberta patients are people affected with MS are dealing with the exact same thing. So it is a universal thing across the country. Absolutely. But it's frustrating.
Yeah, I didn't mean to be BC exclusive.
No, absolutely. But I'm just saying we have a lot of Alberta people here today. So I'm just saying that, everyone deals with this issue. It's really frustrating for sure.
Yeah, no, it is frustrating. And it is very frustrating. So I will take that back to my office on Tuesday and talk to some neurologists about it. And, that your feedback is very important, right? Because the provision of specialized care is it should be accessible and we may have to tweak some things.
Thank you very much.
Any other questions before we close up?
Marcy, it's Amy here.
Hi, Amy.
I just want to say something in regards to what Sherry was just saying.
Sure.
It's not just outlying area. I'm from Prince George. I'm the facilitator for our peer support group. And it's not just outlying areas that are having that problem. if that makes any sense. Co-facilitator and I talked to the clinic here on how to resolve some of those issues. Are you part of our, well, you probably wouldn't be part of our Prince George peer support group, would you?
No, well, I am overseeing all the facilitators now nationwide, so I'm the contact person for the MS Society.
Okay, sorry, not you, Marcy.
Oh, sorry. And
sorry,
Nancy.
the lady that was just talking, Sherry, is it?
Sherry's up in Fort St. John. Nancy's the nurse who's doing the presentation.
We're having the same problem here as Sherry is what I'm trying to get at.
Oh, okay, yeah.
And I live right beside the clinic.
Gotcha.
Basically, right? So we did some stuff with the clinic, and we come up with this thing about phoning and leaving messages and all that kind of stuff. If I could probably send that to you, Marcy, and you could send it on to Sherry, maybe.
Sure, absolutely.
But
Yep.
it might help her a bit, it may not, but just
Definitely.
in case, just for some help anyway.
Absolutely.
Okay, bye.
Thanks, Amy.
Thanks, Amy. Any other
and-
questions?
Sorry, Marsha. Amy, if you were talking about the contact information and details about the clinic that I sent you earlier, I can send it right now to Sherry. Just let me know.
Yeah, you just took that off our Facebook page though? Is that where you
Yeah.
got it from? Yeah. Yeah, if you can, that's great.
Okay, I will
But
paste.
I also wanted her to know that it was something that we have been dealing with here. And it's not to feel alone, I guess. But this is what we came up with and how to deal with it. So.
And to add to Amy's point, please join our Facebook group chats, MS Society ones, or even our Prince George group chats. We share all the problems and we try to find a solution for it. Again, just the feeling that we're all in this together. Yeah, that will be it from me.
Bruce, do you want to go ahead and do the closing then?
Absolutely. So thank you, everyone. Dear Nancy, I know how incredibly busy you were. So thank you so much for putting your time to be with us today and your thoughtful speech and answers. I also want to thank our amazing cloud advisor and the main driving force behind our webinar series, Dr. Rihanna Robinson. This could not happen without Rihanna. Another special thanks to Marsha Spanier, the coordinator of Community Services of MS Society of Canada, for your amazing support in coordinating this event. And lastly, thank you all of you for participating in our webinar. Your participation and engagement means a lot to our team. If you have any sort of suggestions or feedback, please feel free to contact us at the email addresses available in the chat box, and hopefully we will see each other in another speaking series. Thank you.
I'll send the email addresses again when I send the recording later on once it's posted.
Thank you.
Thank you.
Sherry, oh, sorry, go ahead. And Sherry, I will share the Prince George stuff. I can share it right here, or I can email it to you directly. Just let me know how.
You can just send it through email, then I have it.
For sure. I will just hand it to Marsha then.
Okay.
Awesome.
That's it. That's all we have. So thank you all so much for coming. I will again send out the link to the presentation once it's up on the UNBC's website or YouTube site. And again, if you have any questions, you know how to reach me, and we'll talk again soon. Thank you all so much for coming.
Thank you.